Hello, everyone, and thank you for joining us. It's a pleasure to welcome you to this APMEN Tech Talks webinar on early warning systems for vector-borne diseases, lessons from dengue for surveillance and response. So my name is Richard Maud. I'm speaking today as the co-chair of the APMEN Surveillance and Response Working Group. The SRWG is a peer-led technical group that supports countries in strengthening surveillance for malaria elimination and developing systems that can detect important signals early and supporting timely targeted response. It brings together national malaria programs and technical partners across the region to support malaria elimination through practical country-driven knowledge exchange. And today's session is very much in that spirit. So we're focusing on dengue early warning systems because dengue programs in this region have been amongst the most advanced in developing and using early warning and predictive tools. These systems bring together data from disease surveillance, climate, and the environment to help detect and predict changes in transmission earlier to support decision-making. The experiences from Thailand and Vietnam we're going to hear about give us concrete examples of how these tools have been developed, implemented, and applied for dengue control, together with some discussion of some of the challenges and barriers to adoption. For malaria, the role of forecasting is more nuanced, especially in this region. In many elimination and low transmission settings, the priority is less long-range prediction, but more rapid detection of unusual patterns, weak signals, and emerging transmission, and acting on those quickly. So that said, in some settings, particularly where malaria transmission is strongly seasonal or climate sensitive, forecasting tools may add value as a complement to routine surveillance, especially for preparedness and planning. And there are efforts underway in several countries in our region to develop such early warning systems for malaria. So this session is deliberately focused on implementation. It's not just how models work, but how systems are used, how data and assumptions are handled, and how signals are translated into action. After the presentations, we'll have time for some Q&A with some panel discussions to reflect on some of the practical issues in particular. And I encourage you to share your questions and experiences. And I'll go through some mechanics for how we'll run the webinar. So the audio and video of the attendees will be disabled, but you can leave comments in the chat box. And if you have questions, use the separate Q&A link. So there's a Q&A box where you can put a question. So there'll be two presentations, and then we'll take the questions at the end. So there'll be a Q&A session. If you specify the speaker to whom your question is addressed, it helps to direct the question to the right person. And then you can also vote for questions. So if you see a question that you like, you can vote, and those with the highest votes will get attention most, and we'll try and get to those first. And at the end, we'll have a quick poll just to get your feedback about how the whole thing went. So I'd like to thank the speakers in advance, and also the APMEN Secretariat for organising this. And then with that, I'll hand over to our facilitator, Chowrat Rotajana Praset, who will introduce the speakers and guide us through the programme. Thank you.
Thank you, Richard and Marina. My name is Chowrat Rotajana Praset. I work at Moral Epidemiology. My background is biostatistics, and I'm doing work on spatial epidemiology and spatial temporal analysis. And today we are honored to have our speakers, Dr. Dung Bung. He is an associate professor at the School of Public Health at the University of Queensland, and Mr. Kien Gok Du, who is a senior epidemiologist at Louis Pasteur Institute at Vietnam, Ho Chi Minh City. And today they will talk about the eDengue project, which is funded by Wellcome Trust to develop and evaluate the dengue surveillance system in Vietnam, particularly in Ho Chi Minh City. And another case study would be from Thailand, led by Dr. APMEN, who is at the Department of Disease Control, Ministry of Public Health in Thailand, who's leading the eWalls project in Thailand. At the moment, Dr. APMEN is not present. Maybe I'll invite Dr. Dung Phong and Mr. Kien to present the dengue project first, and then we follow up with the eWalls in Thailand. So if you are ready, you can share your screen from the eDengue project and introduce yourself and your project.
Yeah. Thanks very much, Chowrat. Could you hear me well?
Yes, I can.
So let me share my screen. Oh, someone else is sharing now. Is Apinia is sharing now?
Good morning, everyone.
Uh,
Sorry for late framing. This is
so because Apinia here, so I let him present first. Is that okay, Chawara?
Yeah.
At the running
Dr.
process.
Pia, are you ready to present?
ได้ครับ Yes,
Okay.
yes. I will share the screen now. Wait a minute, please. Can you see the PowerPoint? Sorry,
Yes, I can.
it's wait a minute. So, yeah, uh, so good morning, everyone again. I am Apinya Nirmit from Department of Disease Control Thailand. So today I would like to share some of the activity of surveillance system and warning system uh, uh, for the dengue in Thailand. So the topic is early warning and response system in Thailand in terms of development, implementation, and also application. Application, yes. So first of all, again, so actually maybe everyone know that the vector-borne disease are closely associated with the environmental factor, and change in the environment can lead to change in disease vector and subsequently result in an increase in the number of the patients. For example, the environmental factor that influence the vector-borne disease include temperature, rainfall, humidity that will be affect the breathing site and the spread of the vectors. And in Thailand, for the surveillance system for dengue, we have established the data collect over a relatively long period of time. So this allow us to observe trends in the number of cases, dengue cases, which often show a cycle pattern across multiple years. It can be seen in some year that dengue outbreak, and that year the total number of cases will exceed 100,000 annually. When we examine monthly cases, number of cases for each year, it's clearly demonstrate a seasonal pattern. So this indicated that a period uh, that's suitable and temperature, rainfall, and humidity are associated with the higher transmission. Uh, in this graph, you can see from May to August, that is correspond to the rainy season. The number of dengue cases is increased, and the pattern is consistently observed every year. Regarding for the surveillance system, particularly case-based surveillance, uh, Department of Disease Control by the Bureau of Epidemiology has continued develop the reporting system from past to the present. And currently, the system is a digital surveillance system, meaning that the cases are reported electronically, stored in the cloud-based, and can be compiled and visual in we call semi-real time. So it will be verified first and then upload into the cloud based system. And the system can display the distribution of case by time, place, and person. For example, case by the number of age, case by week or by geographic location, down to district or sub-district level. And by this reporting system, it is evident that the passive surveillance in Thailand has been highly developed and is now fully digital. However, this is the dashboard that you can see the case by age group, province, and epidemic week. However, a key challenge in dengue control is the intervention and are often implemented only or after the case has been reported or outbreak has already occurred in the community. As a result, control measure can be delayed or implemented is too late. So since they follow the occurrence of a reporting case, therefore there is need to explore approach that enable prevention or control action to be implemented before cases or outbreak actually occur. In this response to this need, the Department of Disease Control through the Bureau of Vector-borne Disease has adopted method and software package to estimate the probability of dengue outbreak and to provide weekly alert for each area from the WHO, World Health Organization, and TDR. And this package software is known as Early Warning and Response System, or EWARS, for dengue outbreak. Within the EWARS package or EWARS system, the environmental data, the environmental data, for example, the rainfall, temperature, and humidity must be collected specifically weekly. And this data are then entered to the EWARS program. Before enter to the EWARS software or program, the temperature and humidity will be calculated as an average bi-weekly, and rainfall is calculated as the cumulative for that week also. Once these data are entered to the EWARS program, the system will be calculation and generate output indicated the probability or likelihood of a dengue outbreak for that week. And this probability is then will be this one. The probability will be calculated, and then this probability is then compared with the predefined threshold value to determine whether it exceeds the set criterion or not. If the probability is exceed the threshold, it is considered that there is a risk of the dengue outbreak in that particular week, and then an alert is issued for that week will be occur. So this is the basic for this system. And if weekly alert occur consecutively, it's indicated an increasing likelihood of a dengue outbreak. In the particular, the presence of alert over multiple consecutive weeks suggests sustain higher risk of dengue transmission. And from the guideline, Bureau of Vector-borne Disease have the guideline to be implemented action weekly according to the probability of the or likelihood of an outbreak also. So with that, in initial phase for the beginning, we decided to set a meteorological station that will collect the weekly data on temperature, rainfall, and humidity. These data are processed and calculate weekly average and cumulative for the rainfall and subsequent entering in the EVOL program on weekly basis. This process produced a weekly. This is the data that we collect from the area, the temperature, humidity, and rain, and then we calculate for average of temperature and humidity and the accumulation of the rainfall in that week. And then this process, when we entering these three variable, we estimate the probability of dengue outbreak along with the corresponding alert and yes, and you can see it is same as previous one that in the real world it can calculate for the probability, and then if it's above the cut point, the threshold, it will be have alert in that week. However, establish and maintain the meteorological station for collecting the data, and also when we put the data onto the EVOL system by manually, the local public health personnel are required to spend additional time to performing this calculation and manually input the data. Furthermore, operations such as the weather station may be cost related to electricity supply or internet connectivity for the transportation, data transmission. This factor may limit the usability and challenge to long-term sustainability of the system. So therefore, to enhance sustainability, so we to enhance sustainability and overall efficiency and further improvement are needed. So we, Bureau of Vector-borne Disease, Department of Disease Control, shift the data source from self-installed local station to use meteorological data from the Thai Meteorological Department. So most meteorological station of Thai Meteorological Department are located in urban area, and they have a continuous collecting data on temperature, rainfall, and humidity. And in additional, maybe feedback from the user is that the EVOL system may be further developed, so the local user no longer need to manual entering the data And if they can directly view the outbreak alert, moreover, enabling user to access this alert through a mobile application is maybe convenient and maybe practically applied to the EVO information. With that feedback and also in terms of sustainability, so we collaborate with NECTEC to create this one. So we collaborate with NECTEC to develop an enhanced system to automatically import both data source from dengue cases and data from meteorological department into a central server. So we investment to buy a central server, and at the central server, the calculation of probability of a dengue outbreak. And also for the new version of the EVO, the system also capable to predict the future dengue cases. So the result include the weekly outbreak alert and also the observed dengue case and also the predicted cases, number of cases that generated by the EVO software. And all of this will be displayed on the mobile application that we call the name of the application is Rutan. So Rutan application is somehow like before the dengue outbreak is occur, you will be aware, stay alert, and can protect yourself before the case is occur. So this is the Rutan application. So for the mobile application, Rutan is connect to the central database and display the dengue cases. This is the basic that they can show. Sorry, it's in Thai because this application is now is only in Thai language. So they have the number of cases, and then they compare the number of cases with the 5-year median for each corresponding week. And if the number of cases in a given sub-district of that week is higher than the average, the 5-year median, it's indicated that this area have a chance or is the outbreak area. In addition, the application also present any other health-related list, such as the air quality, PM 2.5, and also the heat index. It's already can display in this application by the first version. So for EVO, so furthermore, the Bureau of Vector-Borne Disease has integrated the EVO early warning component into Rutan application as a new feature, and this enhanced provide the advanced alert on the risk or likelihood on dengue outbreak, as well as the forecast of the expected number of dengue cases in coming week. You can see in this slide that they have a solid line. That is the reporting cases, and then the dash line, that is the predicted case. And the number of predicted case can forecast for 6 weeks in advance. And also you can see this one is the level of the alarm level. Is the alarm level. So the week that have more consecutive week of alarm signal will be have more risk of the dengue outbreak. So and also we have the intervention related or correspond with the level of the alarm level. For example, if the alarm level is above 2, it's indicated that in that area must perform the campaign to reduce the source of dengue larva source will be reduced by seeking the container and then destroy it in any setting, not only in household but in also in the school, in the temple, or any other the setting also. So this alarm may be alert before the outbreak is occur, or even before the cases is occur in that particular community. Now we have this information in 80 district in 80 province, and actually we have a plan to expand more information of EWOR like this in the Rutan application. And important one is to evaluate the effect of this kind of information. So after it's maybe alert or indicated that this area should have some kind of intervention, and then the community done some intervention, we would like to evaluate that it's affect the breeding to the reduction of breeding size of dengue or mosquito larva or not, and for the impact, it can reduce the number of cases or not also. So this is from the past until now that we develop and use some kind of information that warning and then trigger some activity in our community for dengue. So I think maybe that's all in brief and short for this presentation. Thank you.
Okay. Thank you, Dr. Pinya, for introducing the EWALS project in Thailand. And then we move to another project, which is e-Dengue, which developing the dengue solar system, but in Vietnam. So Dr. Dung Phung and Mr. Ken will present on that project, and then we will respond to questions in the chat box after second presentation. Dr. Dung.
Apinia, can you stop sharing?
Share the slide again, right?
Stop.
Oh, stop. Okay. Sorry. Okay.
Let me share my screen. Have you seen my screen?
Yes, I can.
All right. Okay. Right. Good afternoon, morning, evenings, where you are from Brisbane. My name is Dung Phung from the University of Queensland. Thank you very much, APMEN, for inviting me to give a talk and to join the discussions. I think is very important today. Different from EWA, congratulations, Apinia team, to apply the existing dengue early warning tool, that's EWA, that has been already developed, so it's used now, and I'm keen to learn more in the futures about the effectiveness and values of the applications of EWA in the system. So different from EWA, e-Dengue tool hasn't been applied in the routine surveillance and preventive system in Vietnam yet, because our project is going on. So today is I just share with you our developmental process of the e-Dengue tool, and I'll share with you some preliminary results of the project. So the e-Dengue project involved a multidisciplinary team of experts from the multiple institutions, including Yale from US, the number of the university from Australia, Japan, and primary collaborators from Vietnam. We developed a user-friendly digital prediction tool for dengue preventions, focusing in the Mekong Delta region. And the project is funded by the Wellcome Trust Fund for 5 years from 2023 to 2028. So that's why I mentioned that our project is going on now. So what I'm going to share with you include the why we need the project, why we need a tool, and the aims of the project, and the activity that we have been implementing in order to achieve the aim, and then share with you where we are at this moment. Nice. I don't think that I need to spend a lot of time for the background. It's all of you know that is dengue is still the big headaches for the public health system. That is still the big problems in the more than 120 countries. Half of the populations, our global population, are at risk of the dengue infections, and that costs billions and billions of dollars annually. Along with the global mobilities and urbanizations is rapidly increasing. Say the climatic factors is a major driver that causes the increase of the suitability of the dengue recently. That especially we know that is a global warming phenomenon. The current efforts to control the dengue is still be the community preventions and applying the reactive approach, waiting for the cases reported from the system and facilitate and mobilize the community engagements to control the dengue outbreak. So as opinion, the previous the presentation you also mentioned the reactive responses have some limitation because that delay the process for the dengue control and preventions in the community. So Vietnam is one of the endemic countries of the dengue. The dengue is a leading cause of hospitalization during the dengue transmission seasons in Vietnam. It is estimated that about 100,000 dengue cases annually reported from the system, but a lot of asymptomatic cases. So that is total number of cases is estimated around the 2 million per year. And the economic cost for the due to the dengue infections, it can cost up to nearly $1 million per year. And some areas in Vietnam are specifically endemic areas of the dengue, like the Mekong Delta region. Thus, we have the dengue every year, dengue endemic every year. So they similar to the other country, the Vietnam National Dengue Control Program relies predominantly on the vector controls in the communities and using the reactive approach. So that is a significant limitations to control the dengue outbreak timely. Now, on the other side of the negative impacts of the climate change, so we are all aware that we are also have some opportunities in order to enhance the surveillance system and preventive system to control, to improve the dengue prevention and control. Like the digital technology is rapidly developing, and that can help us to incorporate the big data from the multiple factors like the climatic factors, socioeconomic factors, to develop the prediction models, and then we incorporate the models to develop the digital tool that can be used by the local health department to inform the proactive intervention rather than the reactive intervention that we are doing now, in order to empower decision makers, to scale up the prevention and preparedness, and allocate the resources for the dengue outbreak responses efficiently. Developing the early warning tool for the infectious disease is not the new thing. A recent systematic review found that is about 37 prediction tools have been developed for the different infectious disease, and majority of the tool is from for the vector-borne disease like the malaria or dengue early warning system, but very small proportion of the tool has been used in the routine surveillance system and preventive practices in the country. So the question is why? Why a high number of tools have been already developed, but the countries and setting are hesitant to use a tool into the routine surveillance system. For the dengue, based on what I saw from the literature and talk with the partners, we found that the dengue early warning tools have been developed. We have the 7 tools already, including EWA. That's APMEN just provided the presentations on how to use that in the Thailand system, and we most recently developed in Vietnam as well. Now, we go back to the questions why the very small proportions, or we can say that is very few of them have been used in the system. So the 3 key factors that prevent the local health departments use and apply the early warning tool in the prevention and controls of the dengue outbreaks, and also some other vector-borne disease. So the first one is they found that there was inadequate collaboration between the scientists, modeler, tool developers, and decision makers and other stakeholders to translate the model into the practical tools. Say, in summary, that the tool do not meet the needs for the own stakeholder involved in the developing tool, applying tool, and sustaining tool in the system. The second factor is they found that there was insufficient training for the practitioner who would use the tools in the system. You know that local health department do not have the high upskill for using the digital tools or some kind of the modeling stuff. Say, on the other hand, our developed tools may not be user-friendly enough for the local practitioner to apply in the routine practices. So the tools somehow are not usable in the specific health system and locality. The last one is very important. We don't have so far up to date, we don't have the systematic evidence on the efficacy and value of money when we use a prediction tool for the dengue prevention and control. We don't have the evidence yet. So if you apply the early warning tool, how many cases we can reduce, or how much the frequency of outbreaks we can reduce, and how much money that we can save for the system, for the health sector. The tool do not provide the convincing evidence for health authority to adopt the tools in the system. Now, based on the experiences from our multidisciplinary team in research and practices, we believe that for the prediction tool to be sustainably adopted into the routine surveillance system, we must show, according to the concept of EU, that the tool is usable, and effectively used for the disease prevention and control. say useful mean that the tool need to need to be very useful, like the high accuracy of predictions, provide the enough lead time for the local health department to to plan and to execute the proactive interventions to control the outbreak, and using the existing data in the system. Usable mean that the tool need to be readily understandable, user-friendly, and easy to be used in the system. Effectively used mean that the tool need to show the evidence on the efficacy and cost effectiveness in reducing the dengue incidents and outbreaks if you apply the tool in the system. So this process is so we recommend the 3U research framework in the recent paper published in the Nature Communications in order to advance adaptability and sustainability of the digital prediction tool for the climate-sensitive infectious disease prevention and control in general, and for the dengue in particularly. Now, our e-dengue project was developed based on the 3EU research framework, in which we target to achieve the 4 main aims. The first, we build the predictive dengue models that accurately predict the dengue risk from 1 to 3 months in advance at the district level. That's the level is we implement the disease prevention and control in the Mekong Delta regions. And then we incorporate the predictive models into the open source software system with the user-friendly web-based and mobile apps interface aimed at the local health practice node to use to predict the dengue incident and outbreaks at the district level. And in order to ensure that the tool can be usable in the system, we conduct the need assessment throughout the projects in order to identify the needs for integrating the e-dengue into the routine practices of the dengue surveillance and prevention program in the Mekong Delta region. And in the last aim, we evaluate the effectiveness and cost effectiveness of e-dengue in the reducing dengue incident outbreaks using the cluster randomized control trial based in the Mekong Delta regions. So for this moment, we have achieved the first 2 aims, and we are going to conduct the aim for the next couple of years in order to provide the evidence on the effectiveness and cost effectiveness of the tool to convince the Ministry of Health to adopt the tool into the system. So this is a research framework, conceptual framework of the e-dengue project. Thus, we use weather factors, preventive factors, socio-demographic factors to develop the prediction models, and then we incorporate into the digital software system and mobile app, and to help for the local health department to use in order to conduct the proactive responses informed by the e-dengue tool. So we divide our project in 3 main phases. In the first phase, we develop and validate the model. And in the second phase, we develop the digital tool, e-dengue tool, while conducting the need assessment for the first phase, second phase, and we also need assessment for the next phase as well. And the phase 3, we are going to conduct the randomized control trial study in order to evaluate the effectiveness and cost effectiveness of e-dengue tool in the system. To implement the project efficiently and make sure that the tool we develop can be usable in the system, we group our team members in 4 main technical teams. In the first team, led by the Professor Dan Weinberger from the Yale University, he's an infectious disease modeler to develop the model and validate the model. Team 2, we developed the software system led by Associate Professor Vinh Bui from Southern Cross University. And team 3 is about the effectiveness and cost effectiveness evaluation led by the Vietnamese partner, National Institute for Hygiene and Epidemiology. And team 4 is led by the Griffith University, Professor Kodia, to conduct the need assessment across the phase of the project. Now, in the first phase, I don't go very much in depth on the technical side of things. In the first phase of the project, we use multiple factors like the weather factors, land use, and socio-demographic factors in order to generate the prediction models, as many as we can. And then we use some accuracy metric in order to evaluate the accuracy or predictive performance of the models. And then we select the best 5 perform models in order to group into the ensemble model. And ensemble models will be used in order to develop the tool to predict the risk of the outbreak at the 3 levels, high, moderate, and low. So we have tried with the 7 tool principal models using the 3 modeling approaches, including the hierarchical, Bayesian, and spatial temporal models, HS84 models using endemic epidemic states in order to predict the outbreak. And we use a supervised principal component regression that uses a group of the district to predict for another district. And we run a lot of the accuracy metric testing, and then we use results in order to select the best 5 model to create an ensemble model. And the current threshold definitions of outbreak is limited in somehow how they calculate that and how they apply that. So we also conducted some simulation in order to select the most appropriate outbreak threshold definitions in order to apply for the predictions and early warning alert. So I think I can show you a bit how is a shiny app on how it works. So this is the shiny app that show you how the ensemble model to predict the outbreaks to provide us the month from 1 to 3 months in advance where we will have the high risk of outbreaks that we need to conduct the proactive interventions. Okay. Now, in last year, we once we have already got the ensemble models, we got an IT team to develop the digital tool, we call it e-Dengue tool, using the model we developed in the first phase. And we also developed the mobile app linking with the e-Dengue tool. So you can see the e-Dengue dashboard here, in the picture of the e-Dengue dashboard. We have 2 main dashboards. One is the surveillance system, and the other is the early warning system. Okay. So if you have time, you can use a link and to go in, and you can see that you can see how the dashboard is working in the real time. Right, as I said, in order to make sure that the tool we developed, it can be usable in the system, we also conducted need assessment throughout the project in order to identify the needs for developing the model, the needs for implementing the models in the system, and the needs for the sustain the tool in the future. So that all of this kind of needs, that we conducted the qualitative study with the all relevant stakeholders, including the policy makers, experts, scientists, practitioners in the local health department, and community members as well, in order to understand the acceptability, feasibility and everything that can make the tool usable in the system. Now, in the next couple of years, we are going to conduct the cluster randomized controlled trial study in order to evaluate the effectiveness and cost effectiveness of the e-dengue tool in reducing the dengue incident and outbreaks, in which we randomize them in two groups. One group will be conducted with the proactive interventions informed by the e-dengue tool, and the other group we conduct the routine practices. That's the reactive approach that they are doing now. And then we will compare the number of dengue cases, or in other words, is dengue incidents, frequency of dengue outbreaks, vector entomological index, and cost effectiveness outcome, like the DALI, like the money, how much money we can save if we apply the e-dengue in the system. So this is very quickly about the approach that we are going to implement the CRCT. For example, we use the data from January to predict the dengue outbreak for April. We are going to conduct the proactive interventions in March in order to, and then after 1 year, we will compare the outcome between two randomized group of districts in order to evaluate the efficacy and cost effectiveness of the tool. So I think that's it. We have already handed the tool to the end user, who are the National Institute for Hygiene and Epidemiology and Pasteur Institutes, to test in the system, and we are going to conduct the epidemiological CRCT study in order to evaluate the efficacy and value of money. And we hope that we can provide the whole package of evidence and the guidance for the Ministry of Health and the provincial health department to apply the e-dengue tool in the system following the project. Yeah, I think that's it. Thank you for listening.
Right. Thank you, both speakers, Dr. Punya and Dr. Jung Fung, for your presentations. We have quite a number of questions in the chat box. I'll choose some of those to other speakers. I think one common questions from our audience is about the area of implementation of the early warning systems. So can you talk about your area, whether it's will be carried out at the district level or sub-district level for your control measures, and if it's too wide, how would you prioritize the control activities in that area? So maybe we can start with e-walls in Thailand. If
Thank you for question. For the level of implementation of the e-wall software or system in Thailand, first we implemented in the sub-district area, and we found that the number of cases is too small. It's less than 10, and for the prediction from this kind of software or warning from this kind of software, it's not much accurate. So now the level of implementation is district level. So and because the meteorological station is in the district level also. So now in our project, we use this tool for the district level, and then we inform for the district health office and then staff of the district health office that if they have a warning or trigger of a possibility of outbreak occur in that district, they will do intervention according to the level of uh, warning that occur that informed by the EWAR system. So now it's in the district level. Yes.
District level for EWAS Thailand and for Dengue in Vietnam.
Yeah, say I agree with Apinia that is we are also trying the model development for the commune level, but but we also got a technical problem, but because the number of cases was very small, and when we developed the prediction model for the commune level, we have a lot of noise for the predictions. So we are still pursuing that one, but for this moment, while we are doing that, we apply the prediction models and prevent proactive interventions at the district level, or we call the regional health center based area. Say once we got the alert for the specific district, we will collaborate with the provincial CDC in order to facilitate, in order to plan and then implement the proactive interventions in the hotspot within the district, identified by some criteria and the local health department. We have here Quốc. We can say that Quốc is a practitioner senior epidemiologist and working at the Pasteur Institute. That organization is leading the disease prevention and control in south of Vietnam, and the Pasteur Institute in Ho Chi Minh City is an end user of dengue. And Quốc may add more detail on how to implement the proactive interventions informed by the dengue in the local health department.
Yeah, thank you, Dr. Dũng, for your quick introductions. So my name is Kiên Quốc, and I'm working for the Pasteur Institute in Ho Chi Minh City. Later, I will name as the PI. For the utility of dengue right now, based on the alert of dengue, the proactive SOC reductions combined with the community engagement will be triggered following the warning sign from the dengue. In particular, we monitor the forecasting results from dengue monthly, and whenever we receive a warning sign from the dengue tool, the provincial CDC will coordinate and communicate with the commune health stations to carry out the SOC reduction, the proactive SOC reductions combined with the health educations. So that means that the health education will be delivered to the whole area through the loudspeaker. And for some very remote area, they use the portable loudspeaker to ensure that the health education message can reach to every household in the area. In the same time, the SOC reductions will be triggered within 1 week from the dengue warning, from the dengue alerts. So that means that at the very preliminary phase, CDC will conduct the lab survey so that we will investigate the proto index, house index, and container index prior to the SOC reductions activities. And then based on the vector surveys, we will navigate the activities of SOC reductions, which means that we will inform the health volunteer, the high-risk breathing water containers, so that they will pay attention to eliminate it during their household visits. After the training phase, the health volunteer will visit every nominated household. In there, they will mobilize the household to carry out the intervention measures, such as scrubbing the water container, or covering the water container, or releasing fish and collecting solid waste or garbage. And after the SOC reduction campaigns, we conduct another lab series to reinvestigate again the BI, HI, and CI, and then we evaluate the effectiveness of the larva eliminations during the salt reductions. And we keep on tracking the number of dengue cases in the following weeks to evaluate whether it brings any impacts to the community or not. So that is the way that we operate the proactive salt reductions in Vietnam following the dengue inform. Over to you.
Great. Thank you, our speakers. Marina, I'm not sure that I think we over the time a little bit. Do we have time to respond to maybe one more question, or we have to do the logistic and close our TikTok?
No, it's on Charat. I think we can go up to maybe another 5 minutes, and
Okay.
then we can have a quick poll from APMEN's side. Oh, I think phone just informed me that we can go up to 10 minutes.
10 minutes, okay.
Mhm.
Since our audience there, we are working on malaria elimination. So maybe from your perspective, how if we would like to adopt or adapt this early warning system from dengue to malaria, would be your suggestion to adopt and adapt this early warning system to malaria context? Maybe Dr. Pinya, if you're still around.
I think dengue is as I showed that is related with the seasonal with the climate, and for malaria I think it's also related. It has some pattern of cases of malaria cases that related with the seasonal. So I think malaria is one of the disease that sensitive to the climate. So if we apply these two for the malaria, it's possible. And once again, it's maybe it can predict or trigger the intervention before the malaria outbreak will be occur in a particular area also. So in my opinion, we can apply this kind of tool for the climate sensitive disease, that is malaria, dengue, or any other that have a seasonal pattern. Yes. So can apply for malaria in my
Okay.
opinion.
Thank you for your team and for dengue. What is your perspective on this?
Yeah, I agree that is in principle we can apply the model to the other vector-borne disease that is highly sensitive to the climatic factors. But however, the features of the vectors transmissions, the characteristic of the populations and environmental factors for the different area, different countries may have the different characteristic and features. So we can apply that, but before doing that, I think we need to validate the model in order to ensure that the model can be adapted by the way that can provide the accuracy prediction rather than it just apply it for the new disease arrival rate.
And how about evaluation? Can we apply the same framework to evaluate others?
Yes, so you can because all of the model have been developed and provided the coding in the GitHub software, GitHub and some other open source. So we can use that in order to see what are the factors they use in the model, how they run the model, what are the structure of the model, and then we use some accuracy metric in order to compare the predicted cases with the observed cases in order to evaluate the accuracy and also the probability of the predictions. So once we have the reach up to the acceptable levels, as we can adapt the model in order to make it is more accurate for the specific location or something like that.
Right. Thank you. And Kenji, do you want to ask something for Dengue? If not, I think for another question about the risk factors. So there are questions about other than the weather station or climatic factors, would you suggest to include other risk factors in the model rather than just the weather data? Maybe
I,
can you hear the question or?
Yeah, I could hear the questions. The question is about what kind of risk factor we include in the model, right? As I said that we for the process of developing the model, we usually use as many as factors as we can in order to generate the own possible models, and then we validate the accuracy to select which one is the best perform model to apply for the early warning tool. I can share with the network the papers we published for our model. In that we provide the detailed descriptions on what kind of risk factors and what is the structure of the risk factor we apply in the ensemble model.
Thank you.
I think I can share now the link of the paper. Let me find out the link and then share in the chat box.
That would be great. Thank you, Dr. Dunfu. And Dr. Apinya for EWALS.
For EWALS in our database, actually we also have the lava index that now we reported by electronic also. But we face the problem that when we explore the quality of the data, in some area it's not much good. So the lava index is one of the parameter that is potential and very interesting to input into the model, the EVOL system. But the quality of the data reports is also concerned to make more accuracy for prediction or warning. Yes.
Yeah, thank you for your responses. I think we almost done with the time, and there are other interesting questions, but unfortunately we don't have time to respond all of it. But I think some of those can be looked over at the papers of the EWALS or eDengue that published previously, and we can provide the link to those papers after the talk as well. So maybe we have to hand over to Marina to close the meeting. And we would like to thank our speakers, and we are honored to have you here. And we can follow up with our collaborations in the future as well. Thank you. Over to Marina.
Thank you. All right. Yeah.
Thank you very much. So we just have a really quick poll that we typically do for the APMEN Tech Talks, and we welcome your feedback on our usual events. Additionally, as per usual, Dr. Phone will be uploading the webinar recordings online on our APMEN YouTube channel, so you can follow the discussion questions and the presentations from the video recording there as well. We will be collecting slides from our speakers requesting their approval to share among the APMEN audience, and we will be publishing a blog post about the webinar with the integrated slides for your review later on. So for those questions about the slide access, you will be given access after we develop these blog posts and communication materials in the coming days. Thank you very much for your interest, and thank you for your attention and time.